One. Please start, ma'am. We are live.
Yes, good evening, everyone. It's a great pleasure to welcome you all for today's webinar, Advances in Hepatocellular Carcinoma Management, organized by Dr. Mithun Sharma, sir. Sir is the Director, Consultant Transplant Therapy, Hyderabad. Welcome, sir. Please start.
Yeah, so I think today is a very important day because we have been able to get most of the doctors fraternity together, because normally we hardly see a hepatologist and an oncologist and intervention radiologist together in a webinar. It's usually a monologue where the hepatologist speaks and the others just listen and nobody to counter. So today we hope for a very interactive session. So we have three hepatologists here. One talking on what is the scenario. One will be talking on the immunotherapy, one on the TKIs, and then we have a talk on the real life experience. Also, we have the oncologist perspective, and finally the intervention radiologist who will be speaking on the intervention measures. So with this, I think I would like to call upon the first speaker, Shantan. Shantan, he is already there live. So Shantan, you can take over with your presentation.
Good evening, sir. Thank you for the introduction. I'll just start off with my presentation. So today I'm going to speak about the pathogenesis and the screening of HCC and where do we stand currently, and visions. Yeah. Can we go ahead, please?
Okay. Yeah, it's visible. You can go ahead.
Yeah. So today the topic of discussion from my part will be the HCC pathogenesis and the screening and where do we stand currently. So the basic outline of my presentation will be on the burden of disease, the pathogenesis and the screening. So at present, there is a lot of global variation which can be seen at the incidence of the HCC. And comparatively, when we are seeing it is largely pooled and the highest burden is seen in the east part of the Asia and the sub-Saharan African region, where the medical resources are often limited, and on further screening there will be much more incidents which we can see. Coming to the facts, where the hepatocellular carcinoma, according to the latest WHO data sheet, which is the third most common cause of the cancer-related death worldwide, with more than 80% of HCC occur in the low resource and the middle resource countries. Previously, it was on the data sheet. 2018 was the 4th position. Now it is the 3rd position, correct? The survival in different countries in patients with HCC, we can see the patients with Taiwan and Japan with the highest survival ratios and survival time compared to the other countries, largely corresponding to the stringent screening strategies which have been attributed by these countries, and hence the overall can be overall detection at an earlier stage. Hence, there is imminent need of stringent and intensive screening strategies by various countries and various societies which has to be done. Coming to the current topic, which is the pathogenesis of HCC. In the patient, in the liver, for the development of HCC, it evolves in the various stages of evolution, where the carcinogenesis occurs at a multi-step process, where there is a chronic hepatitis. With the chronic hepatitis, there is development of cirrhosis in most of the patients, which is there, and further the patients develop into a large nodule or adenoma and later into the cancer. Cirrhosis itself is a pre-malignant irrespective of etiology. There, the liver cell dysplasia may be the intermediate step, while around almost 60% of cirrhotic livers contain HCC and only about 10% in the non-cirrhotic livers. As a HCC, along with the various other cancers, which can see, the normal key phenotypic characteristic of any cancer cells mainly corresponds to first, initially the self-sufficiency of the growth signals which are there for the growth of the cancer cells. There's insensitivity of the growth inhibitory signals. There's evasion of apoptosis of the cancer cells, which corresponds to the increased production and increased lifespan of the cancer cells. There's limitless replicative potentials. There's sustained angiogenesis and tissue invasion and metastasis. So in patients with cirrhosis, what happens with there is various etiology which has been leading to the cause of cirrhosis or cause of the chronic liver diseases with chronic hepatitis. This injury causes a circular event of necrosis and proliferation. So first, the leading to injury leads to necrosis, and this necrosis leads to further proliferation by the various factors which are produced within the liver. And this circle also leads to the production of further hepatocellular activation along with stellate cell activation, which leads to formation, which leads to the fibrosis. And this extensive fibrosis also there will be a proliferative arrest of the hepatocytes. This forms to the leading of abnormal liver nodules and extensive collagen formation. And this also leads to the formation of a shortening in the telomere. As a duration, as a progression of the disease, this extensive liver collagen and formation and increased inflammation leads to formation of a hypoplastic nodule. This formation of hypoplastic nodules with telomere shortening leads to an instability in the genomic in the patient. After the formation of dysplastic nodules, there is marked genomic instability, and the P53 with the tumor suppressor gene, there is a loss in those genes leads to the hepatocellular carcinoma. As I was just stressing on the NAFLD, the HCC pathogenesis, because of the obesity, metabolic syndrome, and type 2 diabetes, there is increased insulin-resistant hyperinsulinemia, as everyone knows. This leads to the formation of NAFLD. Only presence of steatosis without fibrosis is still suspicion of development of HCC, but whether later on with the formation of hepatitis, whether it's fibrotic or non-fibrotic or cirrhosis, which lead to the formation of HCC. The TNF, which is a major adipose-derived cytokine, is the activator of many pro-oncogenic pathways, leads to the signaling and leads to the HCC formation. So many of based upon the ETL list, there are further activation of P53 in the other toxins along with hepatitis B and hepatitis C. So the various pathogenesis includes the activation of the inactivation of the P53. There's persistent inflammation which goes on within the liver. There's oxidation stress, and there are all microenvironmental changes. So these changes act on the liver, and there will be a genetic alteration which will be going on and leads to formation of hepatocellular carcinoma. The hepatocellular carcinoma, the various genetic changes which have been formed have been mentioned in this, where the first major gene which have been detected is the DNA JB1 PRKK gene. This fusion, this leads to genetic rearrangement, and there are various somatic mutations which happen within the liver, which leads to formation of a nodule or HCC. Further, these mutations further lead into epigenetic changes and further molecular pathways, which I will be dealing on slowly. The main genetic alterations which seen in the hepatocellular carcinoma are the third mutation, the third promoter mutations, which almost makes up to 60% of the changes, and later on to the P53 mutations, which are around 30%. Cirrhosis leads to dysplastic nodule and further into early and progressed hepatocellular carcinoma. Based upon the various genetic signatures, various upon the genetic proliferation factors, the HCC again in the molecular level has been classified into proliferation class and a non-proliferation class. So HCC is classified into the proliferation class and the non-proliferation class. The non-proliferation are mostly inflammatory type, and the proliferation class are again subdivided into two classes, where they have is the WNT TGF beta class subclass mutation and the progenitor subclass. So how does these both differ, the proliferation class and the non-proliferation class? The proliferation class mainly has the mixed variety of HCC and the macrotubular variety of HCC. The non-proliferation class has the steatohepatitic HCC and the cholestatic HCC. The major mutation which are molecular subclass which have been seen is a TGF beta WNT mutation type, and while in the non-proliferative it is the CTNNB1 type mutation. The cell differentiation in the proliferation is very poor, and this leads to more aggressive nature, higher frequency of vascular invasion, and higher levels of serum AFP. While the non-proliferation variant is well and moderately differentiated type of HCC, which is less aggressive and has a lower level of AFP mutations. The signaling pathways are also different in both the classes, where the proliferation class has an mTOR pathway, the RAS MAPK pathway, and the WNT pathway. while the non-proliferation is mostly based on the IL-6 JAK-STAT mutation pathway, and this leads to a less aggressiveness and along with the slow growing nature of the non-proliferation type of HCC. So this slide basically determines that the various pathways at various levels contribute to the JAK-STAT pathway or the mTOR pathway and the RAS pathway. This pathway at the end product at the nuclear level will form a transcription factor which leads to further cell proliferation, leads to angiogenesis, the survival of the cells, and leads later to metastasis. Of all the molecular genetics of all the molecular levels, the WNT beta catenin pathway contributes the majority of most of the HCCs, where it maintains around 40% of all the HCCs. This 40%, this WNT beta catenin pathway, it regulates the liver regeneration and involved in maintenance of the pluripotent stem cells. This mutation and this pathway leads to further development of HCC, as mentioned before. Along with this pathway, there is further at the downstream level, there is production of VEGF, FGF, and IGF-2, these are the factors which are produced by the cancer cells after the transcription changes, and this leads to response of local hypoxia, and interaction of these cells with the hypoxia leads to further progression of the tumor. After the transcription level, there are epigenetic alterations which happen, which are the methylated changes. DNA methylation will be there. There will be global DNA hypomethylation and hypermethylation. This methylation and hypermethylation changes leads to further development of HCC. The final coming up to the tumor microenvironment. Within the microenvironment, why does the body can't fight the tumor? So in the tumor microenvironment, once the HCC develops, there's release of cancer antigens. These cancer antigens will be affecting will be caught by the dendritic cells in the lymph nodes. Once this antigen capture in and presentation to the lymph node, there will be production of many inflammatory markers and inflammatory cells. There will be T cell priming and activation. This T cell priming and activation leads to increased production of Treg cells. These Treg cells, increase in Treg cells, will suppress the immunity within the tumor environment, and this increase in Treg cells causes lesser inflammation and along with the cells, inability of the cells to fight the cancer. This T cells migrate to the tumor and infiltrate into the tumor and just suppressing the microenvironment within the HCC. And hence the cancer cells further cannot be damaged. So this finally sums up the pathogenesis, where this is the cell membrane level, the upper one, and this is the nuclear level. The cell membrane level, the various receptors which have been there. So these receptors change into conformational changes and due to various pathways, the TGF beta pathway, the mTOR pathway, and the WNT beta catenin pathway. These pathways will have an effect at the nuclear level, where at the nuclear level they will be acting at the cell cycle level, and further the DNA repair, the apoptosis will not be happening. Further, there will be epigenetic regulation, where there will be DNA methylation and hypomethylation. And this leads to the development of cancer and further progression. At the microenvironment level, where at the stellate level, there will be increased VEGF production. This VEGF production will be causing increased microvasculature. Increased microvasculature leads to further progression of tumor, and there will be an hypoxic inducible factors which will be producing tumor hypoxia, further leads to increased vasculature. These are the points where the further current the treatments where the immune checkpoint inhibitors will be acting upon at this level, where they will be decreasing the Tregs and increasing the immunity, and this increased immune cells will be acting on the tumors for the destruction of the tumor. Coming to the screening of the HCC, what are the symptoms which the patients present with HCC, whether it's a right upper quadrant pain or the palpable liver mass? Patients also present with new onset ascites, nausea, vomiting, early satiety. But the common clues are the recent worsening of ascites in patient with cirrhosis, the loss of appetite, whether there's rising AFP, or patient is a compensated patient, further develops sudden decompensation event which happened. So what is the definition of screening and surveillance? The screening in HCC means the patient had no symptoms, but the clinician does not have a reason to suspect. But the screening, the patient in an asymptomatic patient, The screening is done to detect HCC early and before the development of symptoms, while surveillance is a process of serial application of this screening test to detect the presence of HCC. What is the impact of screening on survival after diagnosis of HCC? A randomized controlled trial has been done in 2004, which has shown that patients who have been screened for HCC in all the cirrhotic patients, their early detection, early treatment leads to a good survival when compared to the control group. The surveillance and screening of hepatocellular carcinoma, who should be screened, how should be screened, and when to be screened. So the patients whom to be screened are mostly the patients with cirrhosis and the chronic hepatitis B, which I have been mentioning later. And what are the advantages and disadvantages of the screening will be discussed. So whom to screen for the HCC? The screening guidelines for HCC are all patients with cirrhosis, and along with the patients with hepatitis HBs AG positive patients who has chronic hepatitis B, an age criteria has been defined by various societies where the Asian females more than 50 years or the males more than 40 years with a family history of HCC, or any males with 40 years along with an active disease. Active disease has been determined with elevated ALT with a DNA of more than log 5. In HCV patients post-HCR, post-SVR, in these patients, the screening and surveillance should be, it's not yet established yet, but has been proposed as patients who have achieved an SVR. If there's a fibrosis resolution, the HCC risk is reduced and can be avoided for screening. On the other hand, if there's persistent of fibrosis or there's progression of fibrosis or there's superadded other etiologies of NASH or alcohol-related liver disease, in these patients, the HCC risk persists and hence it should be screened. Along with it, in HCV patient who has a persistent HCV genetic epigenetic pre-neoplastic changes, in all these patients, the HCC screen has to be undertaken. What are the screening modalities? There are imaging modalities, there are biomarkers modalities. The imaging modalities, namely the ultrasound abdomen, MRI, and CT. The sensitivity of imaging tools for HCC, a meta-analysis has been done of various studies which have been showed that the MRI has a highest the sensitivity and specificity compared to the other imaging, but because of mainly due to the cost issues, the MRI is not being undertaken at any various centers. However, the ultrasound, the sensitivity ranges from around 60 to 80% for the detection of an early HCC. Nowadays, a new type of abbreviated MRI has been proposed where they do a MRI at a shorter duration interval, including only the diffusion weighted and the T2 MRI to see for the screening of MRI, for the screening of the HCC. The various biomarkers which are regularly done are the AFP, AFP-L3, which is a fraction of AFP, and this gamma carboxyprothrombin, which is a PIVCA2. However, there are other biomarkers which have been under study, such as glypican-3. There is Golgi protein 73, which showed a sensitivity of in various studies of 69 to 95% and a specificity of 80 to 90% with area under the curve ranging from 0.8 to 0.9. There are various other biomarkers which have been studied, like the microRNAs and the non-coding long coding RNAs. And one of the study which showed a 3 miRNA panel, it had an area of under curve of 0.98. Further and further studies has to undergo and further after further determination and further regular usage of the microRNA. There's also liquid biopsies which have been done in various other as a investigative pattern, which has shown that liquid biopsies such as extravascular cellular vesicles, further which are the circulating tumor cells, which are already been studied, further it has to be validated. The meta-analysis evaluating the performance of various biomarkers in the diagnosis of HCC has been undertaken by various studies, which have been showing that AFP around showing an average of 60% of sensitivity and specificity of only 80%, with a higher specificity when we are taking with the L3 fraction of the AFP, and the PIVCA2, which have been showing almost the similar type of the AFP. However, the combination of the DCP and AFP improved the accuracy with a higher sensitivity of 70%, specificity of 94%. In March 2020, the FDA approved the Gallard score, which is an algorithm which combines the gender, age, AFP, AFP, L3, and DCP biomarkers levels and which showed further to detect the early HCC, and which showed that the area under curve almost crossing 0.9. So the tools for HCC surveillance, the imaging tools showed ultrasound, CT, MRI. MRI being expensive and not widely available. However, a newer emerging innovations is the abbreviated MRI with shorter imaging times. Further is being planned. Further, ultrasound, in the ultrasound scan, even it is cost effective, the lower sensitivity, hence cannot determine the small HCCs along with an early HCC. The emerging innovation is the contrast enhanced ultrasound. However, there needs to be standardization of the reporting is still not yet established. The circulating biomarkers of HCC surveillance, the FDA approved tests are the AFP and DCP with AFP-L3. Other emerging bioprotein biomarkers are already in line, and there are even emerging liquid biopsy biomarkers with the methylated DNA markers, mutations, extracellular vesicle-based biomarkers, and the circulating tumor cells. On various guidelines from various societies have been mentioned. With this showed that ultrasound should be done in every 6 months in all patients with cirrhosis, and in patients in which ultrasound cannot be done properly, CT MRI can be undertaken as an alternative. However, ASLD, when comparing the various guidelines, various societies, so almost all the societies say that the screening interval of ultrasound makes up to every 6 months to 6 months. However, in APASL, they have mentioned that every 6 months ultrasound and AFP has to be monitored together. While in other societies, the AFP is at the discretion of the clinician. With a more than 1 centimeter nodule, it should the other further imaging has to be done with the CT MRI or the contrast ultrasound for determination of the lesions. If at less than 1 centimeter nodule is there, a CT or MRI every 3 to 6 months as per the APASL, or if the ultrasound every 4th month up to 1 year, if the size is unchanged. For if there is increase in change, further other investigation has to be undertaken. Thank you.
Thank you for the excellent talk. So if there are any questions, we can take anything there on the chat box. I don't think there are any questions here. So I think Shantan, you can unshare your screen. Yeah, so we move on to the next talk, which is mine. So is the screen visible?
Yes, sir.
Yeah. So the topic that I'll be speaking today is the role of atezolizumab in patients with unresectable hepatocellular carcinoma. So now that this is the disclaimer, and we will be basically concentrating on the IMbrave 150 trial and also discuss what is an unresectable ACC. So this is the outline of the discussion today. The first is, what is an unresectable ACC? Second is a treatment for an unresectable ACC. What is the role of immunotherapy, and whether we have some Indian experience on atezolizumab from our center. So what we should remember in the management of hepatocellular carcinoma, that most of these patients are usually under follow-up of either a gastroenterologist or a hepatologist, and it is usually during a routine screening that they develop a cancer. So basically here we are dealing with two diseases. One is a cancer and the other is a liver cirrhosis. Forget if it is a NASH related or a normal liver background cirrhotic ACC, which are very frequent nowadays, but in majority of the cases, we still see it in a cirrhotic liver. This purpose of this meeting today is to encourage the fact that every subject, every specialty has a complementary role, and there are certain gray areas where all of us can contribute still to make the treatment of ACC far better. So this is the evolution of a multidisciplinary approach in management of patients with hepatocellular carcinoma. Before 2002, whenever somebody had an ACC, The only discussion was whether it is resectable or not. If it is resectable, it goes to the surgeon. If it was not resectable, it's the end of life. Or if it was resectable within some criteria, it used to go for a liver transplantation. So it was oncosurgeon or a transplant surgeon or a GI surgeon. Then in 2002, the first description of TACE came. And this was the period where the dominance of the intervention radiologist started. Some lesions used to go for a transarterial chemoembolization. Over a period of time, there was an evolution of RFA and microwave. So this was a zone where it was a combination of a surgeon, hepatologist, transplant surgeon, and an intervention radiologist. The systemic therapy came as late as 2007 with the first trial of sorafenib, followed by a series of trials. But from 2007 to 2013, there was no new molecules. It was only sorafenib, and then came lenvatinib, and then as recently, the newer systemic therapies. 2012 to 2020 was the progress made during immunotherapy. Initially, it was with nivolumab from 2012 to 17, and then we will discuss the role of atezolizumab, which came into the picture. So there is now a role of everyone, right from the surgeon to the transplant surgeon to the intervention radiologist to an oncologist. And sometimes we see sorafenib being given by a hepatologist, sometimes by an oncologist. Same with immunotherapy. It all depends where we are practicing. For example, if it is a Japan, you know, everything they do by themselves. So it's the hepatologist who do. There's a very thin line for referrals there. For example, if it is Germany, then it's a multidisciplinary tumor board. So in India, we can do mutually whoever is seeing the patients. Why this multidisciplinary approach is needed is that we are treating two diseases. Sometimes the cirrhosis of liver patients come with ACC. You may be able to cure the cancer. For example, a small lesion, we have done a radiofrequency ablation, the cancer goes off. But please remember, the cirrhosis of the liver still remains, and 80% of ACCs still occur in patients of liver cirrhosis. So this is the evolution of the era of systemic therapy, started with the SHARP trial of sorafenib, then all the other molecules started into the pipeline, and then the advent of immunotherapy. This is a very nice slide, which I always like, because those in red shows the graveyard. So it's been a graveyard for many of the combinations. If you see, there are only few in green which survive to be labeled as useful therapies and to be used in guidelines. So coming to the first part of the question, what is unresectable ACC? Is just like asking the question whether the glass is half full or a half empty. Whether he's seen by a surgeon or an intervention radiologist or an oncologist, radiation, or a hepatologist, the definition of unresectable may change. Just today, around maybe an hour back, we had a patient in the OPD, which had the 18 centimeter by 12 centimeter by 16 centimeter ACC, bilobar involving both the lobes, where a surgeon has attempted to resect it and then sent to our hospital saying that the resection was not feasible. His alpha fetoprotein was 22,000. The PIVCA was some around 1 lakh plus. So it's basically the beauty lies in the eyes of the beholder. So who is the first contact decides what is unresectable, but that is not how science goes. So what is unresectable depends on what we use. So there are some standard criteria. We are all aware of the Milan criteria and the UCSF criteria. These are the two criteria which are most commonly used. The Milan criteria is basically one lesion less than 5 centimeters, or it can be up to 3 lesion is less than 3 centimeters, but no extrahepatic manifestations or no gross vascular invasions. The UCSF is a little more liberal, giving up to 6.5 centimeter or a total diameter of up to 8 centimeters. There are multiple other criteria like the total tumor volume, which takes into account the alpha fetoprotein. There is the Tokyo criteria, 5 tumors of 5 centimeters. And then there is a French model, which is based on the number of tumor, and they have a very a cutoff level of alpha fetoprotein of whether it is 100 or 1000. So what we normally use at our center are basically to try to operate or resectability to be defined within the Milan and the UCSF criteria. So these are very old criteria. One, Milan was in 1996, the UCSF in 2001, but both of them still holds good. This is more useful in people who are non-transplantable. So anything below this is transplantable. Also keep in mind that these criteria may be exceeded, or we can overrule this criteria when we have a non-cirrhotic background liver. So then there are also some criteria from the East. These are the Eastern criteria. Out of this, the Hong Kong criteria is something which is very friendly to the surgeons. And if you see whatever criteria you use, the 5-year survival varies between 75 to 90%. So we should be using some amount of science before deciding what is resectable and what is not. Now, once somebody says that the systemic therapy is the only option for unresectable, the answer is no. This you will be hearing later on, that there are so many options now coming up, particularly with intervention radiology and even the role of radiation oncologist being coming up quite significantly in patients with unresectable ACC. So there are options like TACE, which I will not go because we have an entire talk on this. But to just touch base, it can be a conventional test or a deep test, and the response rate are quite good, varies between 50 to 60%. Then there are options like transarterial radioembolization, where we use a radioactive iodine, and glass microspheres are used. Again, these are being used now as a first-line treatment in many countries like Canada when compared to TACE. And there is a very emerging role of external beam radiation. Most of these has been combined with TACE, has been tried as a first-line therapy in Korea, and there are small series has been used in Canada as a bridge to transplantations, but there's still a requirement of large prospective studies. And this is the INSL consensus statement, which has a mention of SBRT treatment. We are all aware of the recent change in the BCLC guidelines. The most important changes have happened in the intermediate stage, that is the stage B, where you can now define patients as fulfilling extended liver transplant criteria, or you can have extensive bilobar disease, which are not for transplant. And there are some which will have multiple nodules, but with a preserved portal flow can still undergo TACE. There is a lot of importance being given to what is called as a downstaging, and from any stage somebody can be downstage and taken up for transplantation. The systemic therapy in ACC, we are aware, no talk on systemic therapy can go without the mention of the SHARP trial, which was between sorafenib and placebo, and they included patients of macrovascular invasions with extrahepatic spread. And the primary endpoint was overall survival and time to symptomatic progression. And if you see that there was a significant difference in the probability of survival, however, there was an improvement in the radiological progression, but there was no patient who had a complete response with sorafenib. This was followed by a non-inferiority trial between lenvatinib and sorafenib, where they used lenvatinib of 12 milligram for above 60 years and 8 milligram for below 60 years. The primary endpoint was overall survival. Again, it showed that lenvatinib was non-inferior to sorafenib in this trial. So this was followed by lenvatinib versus sorafenib's second part of the result, that is secondary endpoints. The progression-free survival was similar between both the arms. There has been some advantages and disadvantages which lenvatinib has over sorafenib. what I feel in real life practice is that it has less of side effect with less of hand-foot-mouth syndrome, and the patients tolerate possibly lenvatinib better than sorafenib. This was our experience at AIG. Anand is here today, so he will be possibly touching base on this, where our median progression-free survival was around 7.4 months, and the mean overall survival was 13 months with lenvatinib. As of now, we should understand that sorafenib and lenvatinib are both first-line therapy, and other drugs like regorafenib, cabozantinib are all second-line therapies. The advent of targeted therapy has been emerging over the last decade or so, and the maximum progress has been made in the line of immune-based approaches. The first enthusiasm was about of nivolumab as a first-line therapy, but again, this study was a study which thought that it would get approval, but it was a negative trial. This led to the rationale for thinking whether we can combine atezo, which promotes T cell activation, and combining it with bevacizumab, which can normalize the tumor vasculature by increasing the amount of T cell infiltration and has an anti-angiogenic property along with an immunomodulatory effect. So a combination of atezo and beva was thought to be effective by reversing the VEGF-mediated immunosuppression and promote T cell infiltration into the tumor, which would possibly lead to tumor death. This is the first study that was happened, the phase 1 study, where they used arm A had atezo and beva, and the second arm had a combination of atezo beva and ateza alone. This study showed a median progression-free survival of around 5.6 months, and there was a longer progression-free survival with a combination of atezo beva. But this was not the study which led to the approval. This led to the pathway for having multiple studies where they thought that it can lead to a great response if we combine a vascular endothelial growth factor inhibitor with one of those IL-1, PD-L1 inhibitors. The recommendations for many of the guidelines are still that atezo-beva is recommended as the first-line therapy. Coming to the I Am Brave study, this is the study based on which we are all prescribing our medications. So this study took patients of locally advanced or metastatic and or unresectable ACC who have not received any prior systemic therapy. They categorized the patient based on the region, Asia versus rest of the world. They excluded Japan from Asia. All these patients, if you see, had a very good performance status, whether they had presence of microvascular invasions or extrahepatic spread, yes or no, and based on the baseline alpha fetoprotein, whether it was less than 400 or more than 400. So they use this at the dose of 1200 milligram for every 3 weekly, and bevacizumab at 15 milligram per kg body weight at every 3 weeks. And they compared with sorafenib. It was a 2:1 open label trial. They used it till there was a loss of benefit or unacceptable toxicity, and they followed up these patients' survival. The co-primary endpoint was overall survival and the progression-free survival, and they had a secondary endpoint where they used both the RECIST 1 and the mRECIST criteria. These were the baseline characteristics in both the arms, atezo, beva, and sorafenib. There was not much significant difference, though there was even some significant patients in BCLC-C, and all of these were cirrhotic patients, and the number of extrahepatic spread was more in patients in the atezo-beva group compared to sorafenib. And if you see, a significant number of patients also received prior local therapy for ACC. So this is the primary endpoint, the median overall survival and the progression-free survival. They classified it whether there was presence of extrahepatic spread or not. They agreed that these were very difficult to treat patients, but even in this cohort of patients, they showed a significant doubling of the overall survival and the progression-free survival. Also, this is the updated data If we see the atezo-bevar, the median overall survival was 19.2 months when compared to 13 in sorafenib. And if you see the progression-free survival is around 6.9 months compared to 4.3 months. And it is a follow-up of around 18 months now. Coming to the response and the duration of response, if we see, there was a significant percentage of patients who had a stable disease when you compared with the RECIST 1, and almost similar with the mRECIST. But there was an ongoing response, and the median duration of response was significantly more in the atezo-bevar group when compared to the sorafenib arm. Also, they tried to analyze the overall survival and the progression-free survival based on the baseline characteristic, and they found that there were some parameters, the people who did not have extrahepatic spread had a slightly better survival when compared to those who had spread. This is also very important when we treat any patient of a malignancy. The quality of life is what worsens very fast when people are very concerned about chemotherapy side effect. So this study also tried to analyze this point. They tried to see the median time to deterioration. If you see, the median time to deterioration was significantly longer, 11.2 months versus 3.6 months in sorafenib arm. And therefore, these patients had a better quality of life, which was assessed at 2 consecutive visits. And it was found they were more happy with this combination therapy. There were always a concern about safety. The most common safety was the risk of bleeding. So this is the risk of bleeding in the atezo-bevar versus sorafenib, 7% versus 4.5%. Treatment discontinuation was definitely slightly more in the atezo-bevar group. And if you see, the significance of diarrhea is also there when compared to sorafenib. And they have combinations of problems like hypertension, loss of appetite, and there can be a rise in ALT. But serious adverse effects were almost similar between the two groups. In this study, before they enrolled the patient, all patients had an endoscopy around 6 months before for the varicella assessment, though now the guidelines say it may not be an extreme necessity to do it. The bleeding rates of grade 3, grade 4 were similar in the lenvatinib and the sorafenib, and when you compare it parallelly with the atezo-bevar group, it is around 6%. So there are other drugs coming up now, like lenvatinib plus pembrolizumab versus lenvatinib. This is the LEAP trial, which has a similar endpoints, and this is a study which is ongoing. There are a lot of studies coming, so I won't be going into the details of all the studies. So this is atezo-bevar, atezo-cabozantinib, pembrolizumab, lenvatinib, and they're trying to this is one study which is in advanced stage, that is the durvalumab, tremelimumab. So all these immunotherapy studies will be soon coming out. But most of what I would like to say, the combination of immuno and TKI has till now not been successful, and it has also been negative in the LEAP-2 trial, which we have just now shown. So the future of immunotherapy could be a combination of many of these therapies, or we do a TACE or a RFA and then follow them up. We are doing this in real life practice, but we don't know whether this is supported by evidence at this point of time. If you see, this is another study. This is a Roche-sponsored study, which is a 7-arm study where they are trying different types of atezo-bevar. They have named it as the Morpheus study of multiple immunotherapy in advanced liver cancers. So finally, please remember, when we are treating these patients, don't forget the liver, don't forget to treat the SBP, don't forget the diuretics. We should always not forget the endoscopic to rule out varices, because these patients should not die of a bleed. Also, many of these patients are sick and they may develop encephalopathy because of sarcopenia, which needs to be taken care of. We need to also identify subtle signs of sepsis and identify them and manage them. Also, nutrition is very important in management of these patients. These patients will have a lot of orphan syndromes. They will be having fatigue, cramps, pruritus. We should see if we can help them in any way. With this, I would end my talk, and if there are any questions, we can take in the end. So I think with this, we move on to the next speaker. So I think it's Arif. Arif, are you online?
Yeah, sir, I'm there.
Yeah. So Arif is online. So Arif will be taking over from me to give his talk now. Over to you, Arif.
Yes. So are my slides visible, sir?
Yeah, they are visible.
Thank you, sir. Thank you, Mithil, sir, for the excellent talk about the HCC management. So now we'll be switching the gears and moving on to discuss about something about the cholangiocarcinomas, or what is this comprehensive genomic profiling and why it is done and what is its role in the cholangiocarcinomas. So these are the disclaimers. So basically this CGP test we do for the molecular characterization of the tumor. So we come to know the genetic alterations which are driving the cancer. So those alterations which are responsible for the cancer growth and survival, we can target it using drugs. So these alterations which can be targeted are called as actionable alterations. So many of the alterations which we find after this CGP test are not targetable, and this we call as non-actionable alterations. So the cholangiocarcinomas are one of the cancers in which we find frequently the genetic alterations, though most of them are not targetable. Many of them can be targeted using the present drugs, and these improve the survival and also the responses and improve the outcomes drastically. So coming to the genomic profile of the cholangiocarcinomas, it varies based on the location of the cholangios. So intrahepatic cholangios are different genomic profile when compared to the extrahepatic cholangios, which have entirely different genomic profile. So the most common alterations which we find in intrahepatic, which can be targeted, are mainly the FGFR and the IDH1 genes. So these genes can be targeted using the drugs. Presently, we have availability of these drugs, and we are using those drugs, and these have improved the outcomes and also they improved the survival. So the extrahepatic cholangios are somewhat different in their genetic abnormalities. So these have predominance of mainly HER2 alterations. These HER2 alterations, which can be also called as HER2 alterations, which can be targeted using anti-HER2 agents. So these, though both these cancers have TP53 and KRAS mutations are the predominant alterations, these are not targetable at present, though we have drugs to target this KRAS. This is specifically for one mutation, that is KRAS G12C, and it has been used in lung cancer, though not with so much improved outcomes. So these are the therapies, and these are the studies which led to the approval of targeted therapies in these cholangiocarcinomas. We have variety of genetic alterations which can be targeted, like HER2 amplifications, which can be targeted using monoclonal antibodies. Though we have not met with so much success in these cholangios, these are some of the alterations which have the future and which we can use the targeted drugs and improve the outcomes. So this can just take the example of the MET amplifications. This can be targeted using cabozantinib. This is one drug which we use also in the HCC in the second line. It also targets the MET gene, so the MET amplification or MET mutations. So this has led to the improvement in the survival. These are two pathways which are frequently altered in the cholangiocarcinomas. Basically, the PIK3 AKT mTOR pathway, and the other pathway is the RAS RAF MEK and ERK pathway. This was one study in the metastatic biliary tract cancers where they did an NGS to find out what was the frequency of the alterations. And also, when we give the therapy according to the genetic alteration found, whether it improved the outcomes or when we use the conventional treatment. So they compared the personalized treatment with the conventional treatment in this study. And in this study, what they found was basically the TP53 and RAS mutations or the predominant alterations which were found, which were most frequent. But as of now, we don't have any drugs to target this TP53. And as I earlier said, that KRAS mutations can be targeted using KRAS inhibitors. It is only approved for a specific mutation, that is KRAS G12C. And we have been using this drug in the lung cancers in the second line, and it has marginally improved the survival and the outcomes. So this was second study where they found the frequency of the alterations. As we can see, out of 30 patients, nearly 22 patients had the genetic alterations. So though the genetic alterations and the mutations are common in these cholangiocarcinomas, most of them are not targetable. The targetable ones are mainly the IDH and the FGFR mutations. So this is again the same slide telling us about the frequency of the genetic alterations. So basically, it is the TP53 which predominates, followed by the RAS mutations. And also we have some targetable alterations like loss of heterozygosity and the tumor mutation burdens. So this is important because this loss of heterozygosity is a marker where we can use the PARP inhibitors as the treatment. So this has been used in the ovarian cancers. It has enormously improved the survival and drastically improved the outcomes in the ovarian cancer. So nearly 10% of cholangiocarcinomas have this loss of heterozygosity, and they can be targeted using PARP inhibitors. So the other alterations which can be found are high TMBs, that is the tumor mutational burden. These are the markers, there's MSI, PDL1 and TMB for the immunotherapy basically. So when they are found, when we use this immunotherapy, this can improve the responses and also the outcomes. So the FGFR alterations are also found. Most of the alterations in the FGFR are due to fusions. So the fusion partner is BICC1, and the other co-occurring alterations along with the FGFR are the BAP1 gene alterations. So these are mutually exclusive from the other targetable alterations like loss of heterozygosity, IDH and KRAS. Meaning the FGFR, if it is found, it is the other alterations like IDH and KRAS are not generally found. They are not combinedly found simultaneously. So the FGFR alterations are common in the basically in the intrahepatic cholangios. The predominant ones are the fusions. The fusion partner is the BICC1 gene, and these are mutually exclusive, and they can occur with the mutations in the other pathways like mTOR, PIK3C and AKT pathways, and thus this highlights that these alterations can be targeted. We have drugs for mTOR pathway, for PIK3 we have got the drugs, and also we can target the AKT genetic alterations. So when these FGFR are concurrently found with these alterations, we can target it using the dual drugs. So as we discussed in the previous slide, that study which involved those patients for studying the genetic alteration in the cholangios, when we matched the therapies according to the genetic alteration found, it improved the outcomes. So as we can see, when we used the conventional chemotherapy in the when we found the targetable alteration, and when we use that matched therapy according to genetic alteration, the survival has improved. So there lies the importance of doing a CGP test and finding those targetable alterations. And when we match the therapies according to the alterations found, it improves the PFS and also the OS. As we can see, the delta is nearly 8 months. So these targeted agents, when we use intelligently and we target it using those drugs, matched therapies, these improve the outcomes and the survival. And look at the disease control rate, it is around 60% with the use of targeted therapy as compared to just 30% when we use the chemotherapy. This is one trial in which involved the 121 patients, where they used both the tissue-based biopsies and also the liquid-based biopsies. And they wanted to see what is the concordance between the tissue-based and also the liquid biopsies. So what they found in the end was that the metastatic site alterations matched with the liquid biopsies. So there was 100% match between the metastatic site and the liquid biopsies. So whatever the genetic alterations which were found in the liquid biopsies were which were found in the metastatic site as compared to the primary site. So the metastatic site has more concordance with the liquid genetic alterations rather than with the primary tumor. So this study, which involved 121 patients, when they treated with the MASH therapies, so nearly 29 patients received targeted therapy, 5 patients received the immunotherapies. As we can see, when they received the MASH therapy, it improved the response rates. So 24 versus 4.7, and also most of the patients did not progress when they were on MASH therapies. Like 40% patients had disease control as opposed to the 65% who lost to progression. So also they improved the median progression-free survival when we used the MASH therapies. So it was 3 versus 4.3. So the MASH therapies improve the outcomes, they improve the survival and also the responses. So the other alterations which can be found mainly in the intrahepatic cholangiosis, IDH1 mutations, these are targetable. We have targeted drugs called ivosidenib. Ivosidenib was first approved in AML. So these have drastically improved outcomes in the AML. It also been tried in the cholangiocarcinomas. So IDH gene is basically a driver mutation gene. So when this is altered, this gain of function mutations in the IDH1 gene produce a metabolite. This metabolite is a carcinogenic. So this leads to the carcinogenesis. So when we target this mutation, we can improve the outcomes and kill those tumor cells, shrink the tumors, and improve the responses and survival. So this is the drug which I was talking about. The ivosidenib is inhibitor of IDH mutation. As we can see from the curves, the survival has improved significantly, 2.7 versus 1.4 months. That is a lot in cholangiocarcinomas because this is a very difficult to treat cancer. As we all know, it's a very aggressive cancer and we have not much treatment for it. And basically the chemotherapy which we give is just leads to very less responses, non-durable responses. After progression, we don't have much second-line treatments. And when we do this CGP, we come to know which the genetic alterations which are driving this cancer, which can be targeted using these drugs. So this is another one study in which they studied the concordance between the liquid biopsies with the tissue biopsies. So we know the tissue is an issue in the cholangiocarcinomas. It is difficult to find the samples. Biopsy samples are most of the times inadequate because the site is very difficult site to biopsy. So when as an alternative, we can use this liquid biopsies to test for these mutations. So it's just we can send a blood sample and this blood sample can pick up those mutations. Though these mutations which were picked up on the liquid biopsies are highly concordant and they can these mutations can be found in also in the tissues. So these liquid biopsy mutations are highly concordant with the tissue biopsies. So this is the IDH1 mutation patients which were treated with ivosidenib. So what are the determinants of the improvement in the survival? One is the variant allele frequency. What is this variant allele frequency? It quantifies the mutation in the blood. So the higher the mutation level in the blood, lower is the response to the treatment. These curves show that the same result, that when the VAF is high, this variant allele frequency, the treatment doesn't work so good. So the survival is also not good. If the variant allele frequency is low, these match therapies and the IDH inhibitors inhibitors work very well. So also we know that when we use these IDH inhibitors, if there's a clearance of this mutation in the blood, these patients have a good survival, as opposed to those patients who don't clear this mutation after using these therapies. So there are other alterations like RET alterations. RET alterations can also be targeted. These patients who have these RET alterations, they don't respond to standard therapies, they don't respond to immunotherapies. Pralsetinib is one drug which is a selective RET inhibitor. As we can see from these two case studies, that it has led to response of around 40% shrinkage in the tumor. In other patient, there was 60% reduction in the tumor. Or they also led to the durable responses up to 20 months. So this RET inhibitor in this RET positive cholangios led to durable response of close to 20 months. So that is a significant improvement in the outcome. So the other alterations which can be found are HER2 alterations. These alterations are basically found in the extrahepatic cholangios. These can also be targeted using anti-HER2 agents. These are the examples of two patients where they were treated with HER2 inhibitors like neratinib. Neratinib is a pan-HER2 inhibitor. It led to stable disease in one patient, and also in other patient, it led to the substantial improvement in the performance status after 4 months of treatment. So these FGFR alterations can also be targeted using drugs. We have drugs for it like pemigatinib, brigatinib. These are the drugs, FGFR inhibitors. These have been studied in both phase 2. There is ongoing phase 3 where they are studying these FGFR positive cholangios, in which the FGFR inhibitor is compared with Gemcitabine, which is the standard treatment for cholangios, and the outcomes are still awaited. So as we have seen earlier, that FGFR alterations are mainly fusions. BCC1 is the most prevalent fusion partner, and also they can co-occur with other mutations like BAP1, and also they're mutually exclusive with the IDH1, meaning that the FGFR alterations, when they are found, IDH alterations are not found commonly. So coming to the conclusion of my talk, the key messages which can be derived from this talk is basically the cholangiocarcinomas are difficult to treat diseases. They are very resistant to the conventional treatment. When we do this CGP test, we can identify those targetable alterations which can be targeted using drugs. And as we have seen, they have drastically improved the outcomes and the responses. And we need additional drugs and additional trials to see whether these are going to become the future of the treatment for cholangiocarcinomas. Thank you for the patient hearing. Thank you.
Thank you, Arif, for that wonderful talk. This is something very new, which most of us are unaware of, at least me. So now moving on from the molecular level to something very real and practical, which Dr. Anand will tell us about the experiences with systemic therapy. Is Anand there?
I'm here, sir.
Yeah, sure. Anand, take over from here. Yeah.
Yes, the slides are visible, right?
Yes, the slides are visible.
Good evening, everyone. It's an important talk given to me from Dr. Mithun. Actually, it's quite interesting. Systemic therapies for HCC, everyone has heard till now. Dr. Arif talk about something about molecular biology. Quite eye-opening for me. So this is in unresectable HCC, current practices and future directions. Only few trials will be discussed. Some slides which I feel will be more time consuming. I will be try to skip them and just be succinct and be to the point as much as possible. So we knew that the incidence of HCC has been gradually increasing. The mortality as well has been increasing. Asia Pacific region actually contributes almost 1/3 of the population, 1/3 to population of the world, and we are the dominant causes for HCC because of the hepatitis B and hepatitis C. There's increasing mortality as well, probably due to poorer surveillance and poorer acceptance of vaccines. while in some countries like Taiwan and Japan, the surveillance and vaccinations are quite strong, and these individuals there have longer survival compared to anywhere else in the world. This was the previous BCLC systemic therapy. If you see there, it was only 10 months survival, while the recent one, updated one, says that the survival with the current available systemic therapy is as high as 2 years, more than 2 years. So these are the available options now. Atezolizumab or the Himalaya trial, durvalumab plus tremelimumab, sorafenib, lenvatinib, regorafenib, cabozantinib, ramucirumab. These are all the ones which are available, but the commonly used ones will be discussed in the next few slides. NCCN guidelines, again, similar line of treatment, sorafenib, lenvatinib, and atezolizumab. Atezolizumab specifically for child age was the initial data, but there have been recent studies saying that it can be used for child B as well. Other options, the only catch about ramucirumab, it's an anti-VEGF inhibitor. If the alpha-fetoprotein is more than 400, then the trial demonstrated that these patients have higher expressions of VEGF and probably better benefits with ramucirumab than those individuals who have lesser alpha-fetoprotein. So the frontline therapies, the first trial, as Dr. Mithun initially said, that the first study on systemic therapy came in 2007, 2008 in NEJM on sorafenib. It was compared against placebo, and there was significant better overall survival, median overall survival of 10.7 months compared to 8 months in the placebo arm. And it held the same in Asia Pacific region as well, 6.5 months versus 4.2 months. Following this, the role of systemic therapy came into picture for HCC. Till then, we struggled for only resection or intervention radiologists. The unique mechanism of lenvatinib, which came into picture later on, after a decade late, it was a non-inferior trial. The only advantage of lenvatinib is it has FGFR4 inhibition, and at a very low dose, it can inhibit FGFR4. That's the basic advantage of lenvatinib. If you see here, HCC have aberrant expression of FGFR. There is increased FGF19, and FGFR4 is both together lead to increased oncogenic driver pathway for HCC. And this, when it inhibited in combination with VEGF, but that is multiple tyrosine kinases, that is VEGFR, FGFR, KIT, and RED, which is more stronger with lenvatinib. At a lower dose, we can achieve a greater suppression of these pathways, and hence it has better efficacy. The only catch here was in the non-inferiority trial, where it included all the patients with child class A, BCLC, B, or C, ECOG good performance status, and in respect of the presence or absence of macrovascular invasion or the extrahepatic spread, the individuals were randomized into two groups, lenvatinib versus sorafenib. Sorafenib was 400 mg twice daily. For lenvatinib, it has been previous to that, they already demonstrated that even for patients with less than 60 kg, 8 mg is sufficient, while for more than 60 kg, 12 mg is required to achieve a drug concentration and to achieve a good response. Importantly, the median overall survival was not significant initially. In the study reported that it was non-inferior trial, while there was significant improvement in the progression-free survival and the time to progression. So this was quite important at the initial, and it was a landmark study which was published in Lancet from Japan, Professor Yam Kudo. Then later on, they had some few variations done to this study, and they also demonstrated that there is significant improvement in the overall survival as well, as I discussed later on. So this was an investigator-initiated and the mass independent imaging review of the patients who received the treatment on MRESIS criteria. Similar to the original study, they said that progression-free survival and overall survival and time to progression was better with lenvatinib, and the hazard ratio was 0.6 compared to sorafenib. The p-value was quite significant in these patients who received lenvatinib. It's a huge sample, almost 470 patients. So there was some discrepancy in the alpha-fetoprotein levels at the baseline. So the alpha-fetoproteins in individuals who received lenvatinib had more number of patients had alpha-fetoprotein more than 200 nanograms. So then they tried to stratify the population, then they matched the population, and they said that the median overall survival was better with lenvatinib, 13.6 months versus 12.3 months, and the hazard ratio did not cross 1, that was, it was less than 1, 0.85, with ranging from 0.73 to 0.99. and the p-value was 0.03. So probably that matching would have probably said that lenvatinib has better overall survival, because in our routine practice, we less frequently see a patient of sorafenib surviving for up to 12-13 months. Most of the patients don't turn up after 3 to 4 months, implying probably they are no more. There are other imbalance as well in the sorafenib arm. As the disease progressed, they received some of the other investigational drugs or the checkpoint inhibitors, and then they noted that there is improvement in probably an improvement in overall survival in this group. Just to justify that probably these patients had better or not better overall survival just because they got second line therapy. When we assessed our own experience on lenvatinib, this was published in GastroHep. The important things to note here: hepatitis B and C are individuals are 21 and 10, while NASH is 28. So gradually we are shifting from viral hepatitis to NASH dominant diseases. And lenvatinib was quite effective in these patients. Although none of them achieved complete response, there are a good number of patients who achieved partial response. Stable disease in almost 40-45%, progressive disease only 30%, and the median tolerated dose in Indian cohort was only 8 mg. We usually start at 4 mg, then increase up to 8 mg. Most of our individuals do not tolerate 12 mg as per the recommendations. The overall survival was 10.4 months, and the median progression-free survival was 5 months. We also noted some adverse events in this group. Lenvatinib suddenly blocks the VEGF, so there is complete cutoff of the tumor supply. There was one patient with tumor rupture. So a patient with larger sizes have this risk of developing tumor rupture if the individual develops severe pain or has come with some other complaints post initiation of the lenvatinib. Think of rupture. There are certain key developments in the recent times. One is the launch trial, that is lenvatinib plus stays for unresectable HCC. We heard Dr. Mithun saying what is unresectable HCC. Atezolizumab, again, we also heard that Himalaya trial, which I'll be telling in brief in the next few slides. This was a breakthrough study published in NEJM in 2020 on the combination of Atezo plus BEV for unresectable HCC. In the initial study, the median overall survival is not reached, while later on it is published in Journal of Hepatology saying the overall survival is around 19 to 20 months. Sorafenib, it was around 13.2 months. And the hazard ratio was quite good in improving the overall survival with patients who received immuno-oncological agent, that is atezolizumab. Similarly, they also said that the median progression-free survival was 6.8 months compared to 4.3 months in the sorafenib arm. Objective response rate was much better with the use of these agents, and the complete response rate was in 10% compared to only 2% in individuals who received sorafenib. Obviously, this being a large RCT, there were several, even smaller adverse events has to be noted. There are a huge number of side effects in both the groups. Diarrhea, tyrosine kinase inhibitors are known to increase the risk of diarrhea, hypertension, and palmoplantar dysarthria, while atezolizumab have their own caveats in causing hypertension. Bevacizumab is known to increase the risk of bleeding. It is a VEGF inhibitor. So these individuals have to undergo endoscopy prior to therapy, and with plus minus banding if required. So these are the key warnings for patients who receive atezolizumab. One for atezolizumab is if the patient has history of organ transplant, history of autoimmune diseases, and immune-mediated pneumonitis, hepatitis, colitis, endocrinopathies are quite often known with atezolizumab, while bevacizumab has the risk of bleed, perforations, fistula, uncontrolled hypertension, and proteinuria and congestive heart failure. These drugs actually basically increase the immunity. So post-transplant, if you give this drug, where we want to suppress the immunity by giving anti-immunosuppressants, they may have increased risk of rejections. Historically said to be around 50%, but the recent data suggests around 15 to 20% if initiated after at least 3 to 4 half-lives. Following the approval of this drug, there has been significant increase in the use of atezolizumab from less than 10% to almost 70%, while the use of tyrosine kinase inhibitors has reduced. But tyrosine kinase inhibitors even today are the bread and butter for all the pathologists and gastroenterologists for non-affordable individuals. We also noted that patients with atezolizumab perform well if the patient is chosen appropriately. Child A patient has a good survival 21 months, while compared to child B of 9 to 12 months, a child C hardly around 4 months. Similarly, the progression-free survival is also dependent on the child PUG score. The next trial, that is launch trial, lenvatinib plus trans-arterial chemoembolization versus lenvatinib alone as first-line treatment for primary advanced HCC. This is a multi-center randomized control trial. This has been discussed in detail in the next few slides. Quite recent study, interesting study to know actually. Advanced primary HCC without any prior treatment or initial recurrent HCC after radical resection without any post-operative treatment. At least one measurable liver lesion should be there, and single lesion less than 10 centimeters or number of lesions less than 10 and tumor burden less than 50%. Again, child PUG A, good performance status and good liver and kidney function test, good performance, and irrespective of the tumor thrombus, that included for TACE plus lenvatinib. TACE was done 1 day after the lenvatinib initiation, while the other group received only lenvatinib. The primary objective was overall survival, where the secondary were again progression-free survival, time to progression, and objective response rate. Within 14 days of taking the consent, the patient was started on lenvatinib at least 3 days prior after the taking the consent, and after within 24 to 72 hours, the patient would undergo. One group would undergo to TACE, and the other group could only receive lenvatinib. So time to untraceable progression was the term coined by that article published in Gut, saying that addition of probably tyrosine kinase inhibitors can improve the time to untraceable progression. So these are the inclusion and exclusion criteria for patients who underwent who were included in this trial. Importantly, the creat was less than 1.5. Median overall survival for patients with advanced HCC who received lenvatinib was assumed, the sample size calculation was assumed to be 10 months, and the median overall survival may be expected to be around 15 months with the addition of len-TACE. So they calculated the sample size of 336 was needed in this study. There are 338 patients randomized to two groups, TACE plus lenvatinib versus lenvatinib alone. 170 received len plus TACE, while only 168 received lenvatinib alone. These are the baseline characteristics, which are quite similar in both the groups. Again, the most common etiology was hepatitis B. Almost more than 80% of the patients had hepatitis B as the cause of disease and had good performance status. Alpha-fetoprotein was more than 400 in around 50% of the individuals in both the groups. Complete response, the problem with these tyrosine kinase inhibitors is to achieve a complete response is quite difficult unless you combine with them with or some other local regional therapy. When combined with local regional therapy, probably we'll see more complete response in these individuals. In this group, in this study, partial response was better with len-TACE group compared to lenvatinib alone. Stable disease was similar. Progressive disease was more in patients who received lenvatinib alone. Objective response rate was better. Disease control rate was also much better with len-TACE. Basically, ORR includes CR plus PR, that is complete response plus partial response. DCR includes stable disease in addition to ORR. So when you see on the MRESIS criteria, there are similar things which was noted. Complete response was better, that is 3%, and compared to only one patient in lenvatinib arm. Good number of patients achieved partial response, 51%. The stable disease was almost similar, although, and progressive disease was more in patients who received lenvatinib alone. Again, ORR and DCR was much better in patients who received lenvatinib plus TACE. The overall survival was 17.8 months in lenvatinib plus TACE arm compared to only 11.55 months in patients who received lenvatinib alone. The p-value is quite significant. Survival without progression, that is median progression-free survival, was also much better in combination arm of lenvatinib plus TACE compared to only lenvatinib. This is quite unusual for me because in the original trial, lenvatinib had led to an overall survival of 13 months and progression-free survival of around 7 to 8 months. It is quite little less over here compared to the landmark study which was published in Lancet Onco. On subgroup analysis, irrespective of the etiology, the ECOG performance status, alpha-fetoprotein, tumor size, portal vein thrombosis, len-TACE group had better overall survival and progression-free survival across all the spectra. The only for predictors of survival and progression-free survival, Age was an important determinant. Bilirubin again was an important determinant, and the treatment allocation was also an important determinant of progression-free survival. That is, len plus TACE had better PFS than those who received len alone. Adverse events were almost similar in both the groups, except for a mild increase in the liver function tests in individuals who received len plus TACE compared to only lenvatinib alone. Because when you do TACE, if the patient has compromised liver function test, there is an increased risk of developing liver failure post-procedure. Curative surgical resection was conducted around 15% of the patients in len-TACE group. Only 3 patients in lenvatinib group received only curative surgery. So TACE plus lenvatinib followed by curative surgery is quite an important thing, because we want to cure the patient even in the absence of portal hypertension, obviously, or the decompensation of the individuals. Curative options can be surgical resection. Otherwise, transplant remains the best treatment of choice. The median duration of lenvatinib administration was 8.2 months in lenvatinib arm compared to only 5 months in the lenvatinib arm. The dosages were 8 mg in both the groups almost, and 12 mg. I think this is a mean dosage of 7.6 mg and 11 mg in compared to 8 and 12 mg group. Thus, the lenvatinib dose reductions, interruptions, and discontinuation was quite similar in both the groups. Patients in len-TACE group were treated with a total of 560 times of TACE. It is altogether 170 patients altogether. And the median TACE session per patient was 3. That is, each individual had to undergo at least 3 sessions of TACE in combination with the lenvatinib. So the authors concluded that lenvatinib plus TACE was safe and effective for patients with advanced HCC, demonstrating remarkable improvement in OS, PFS, and ORR, with similar toxicity as compared to individuals who receive only lenvatinib. So this might be a potential new line, first line therapy for advanced HCC, len plus TACE, while on the other hand, we do for advanced HCC larger lesions, we do TARE or SPRT plus in combination with immuno-oncology agents to achieve a resection, that is ABC, atezolizumab followed by curative resection, or len-TACE followed by curative therapies. Himalaya trial was the recent one published in NEJM Evidence. It is on single dose of tremelimumab followed by durvalumab. They demonstrated that there is improved OS and PFS in the individuals who received a single dose of tremelimumab followed by durvalumab compared to durvalumab alone or sorafenib. I feel that the future studies should compare all these immuno-oncological agents with lenvatinib instead of sorafenib, because we know that sorafenib probably has been now quite slowly getting extinct from the market. So progression-free survival and overall survival was better with single dose of tremelimumab followed by durvalumab every 4 weeks, 16 months versus 14 months, and the p-value was quite significant. The progression-free survival again was much better in the combination group compared to sorafenib alone or the durvalumab. The median progression-free survival, the p-value has crossed the HR has crossed, and it is probably the OS which is significant, not the PFS. Summary and conclusion: contrary to the common perception, there are significant number of HCC cases in India. We know that, and treatment of HCC is challenging because of the underlying CLD and the relative chemo resistance. And the timing of presentation of these individuals is quite late. And tyrosine kinase inhibitors have been shown to be quite effective as a first-line therapy as well as second-line therapy, although I did not discuss as a second-line therapy in the recent in this current slides. Lenvatinib is most likely has better efficacy and tolerability and can be considered as a first-line therapy. Len-TACE appears to be good strategy to the downstage and patients with advanced HCC. And combination of TKI plus immune checkpoint inhibitors, Dr. Mithun has already told that it probably have failed till now because there is increased adverse events in the combination group probably. Thank you.
Thank you, Anand. So for the wonderful talk, it's a lot of new data coming up. So for the constraint of time, we'll just move on to the next talk, that is the role of TKI in metastatic HCC by Dr. Soumya. Soumya, you can take over from here.
I hope my slides are visible, sir.
Yeah, they're visible. Just make it full screen. Yeah.
Thank you, sir.
The object, I would like to thank Mithun Sharma sir and Rosh and Isai for giving me this opportunity. Most of the topics that I will be covering are already touched upon by other speakers today. I'll be discussing about the role of tyrosine kinase inhibitors in metastatic HCC. This has already been discussed. This is the latest BCLC staging and treatment strategy that was published in 2022. The role of TKIs is usually in intermediate stage of HCC and advanced stage of HCC. As we know, the intermediate stage can be divided into 3 different subtypes. Diffuse infiltrative extensive HCC with bilobar liver involvement, which is not amenable for any loco-regional therapy or not be able to be downstage for undergoing a liver transplant, are considered ideal for systemic therapy. And advanced stage, which includes portal vein invasion or extrahepatic spread with preserved liver function and ECOG performance status of 1 and 2 are to be considered for systemic treatment. As we all know, the first line recommended treatment currently is atezolizumab and bevacizumab in unresectable HCC, which has already been discussed in detail. The IM Brave trial, which described the effectiveness of atezolizumab with bevacizumab combination in comparison with sorafenib, which showed good efficacy and higher median PFS of atibev combination in comparison to sorafenib, stands the first line therapy of choice currently. However, there are certain warnings and precautions to be taken for using first line atibev combination. Atezolizumab to be used in caution in patient with history of organ transplant or history of autoimmune diseases or immune-mediated pneumonitis, colitis, or endocrinopathies. Bevacizumab should be avoided in patients with GI perforation or had a major surgery in past 1 month with an incompletely healed wound or history of hemoptysis or a variceal bleed, having a fistula or uncontrolled hypertension, more than 2 gram proteinuria or CHF. And in Indian settings, financial constraints is one other significant factor for considering tyrosine kinase inhibitors as first line treatment of HCC in advanced HCC. The TKIs commonly used in first line therapy in HCC are sorafenib and lenvatinib. The second line TKIs are regorafenib, cabozantinib, lenvatinib, and sorafenib in patients who have already experienced immunotherapy. Sorry for putting ramucirumab there, which is a monoclonal antibody. This coming as a second line therapy. Coming to the first drug, that is sorafenib, it acts by inhibiting tumor cell proliferation, tumor angiogenesis, and increases the rate of apoptosis. It inhibits the serine threonine kinases RAF1 and BRAF and tyrosine kinase activity of VEGF1, 2, 3 receptors and PDGF receptor beta. This was approved in the year 2007, where the efficacy was proven by SHAR trial, which was a phase 3 multi-center randomized controlled trial, which compared the efficacy of sorafenib with a placebo. It included 602 patients, included 121 countries, which was mainly located in North American and European countries. The eligibility criteria for this trial was age more than 18 years, expected life expectancy was more than 12 weeks, childbirth status A, previously not treated cases of HCC with at least one tumor which is accurately measured in 1 dimension using a RECIST criteria with ECOG performance status of 0, 1, 2. So this was approved in the year 2007, and this has been the standard of therapy for over a decade now. Drug dosing and managing the adverse effect plays a major role in treating a patient with sorafenib. In this SHARP trial, sorafenib had a median OS of 10.7 months compared to, which was significantly higher compared to placebo. And one another study which I would like to mention here is Asia Pacific study, where a SHARP study mainly included patients from North American and European regions. The Asia Pacific study included regions from the Asia Pacific region. This SHARP study included patients in 1:1 ratio to sorafenib and the placebo arm, where Asia Pacific to sorafenib and placebo arm in a proportion of 2:1. This also showed higher median OS compared to placebo with a significant p-value. However, SHARP trial showed higher efficacy of sorafenib in HCV related HCC subgroup, and Asia Pacific study showed worse outcomes in hepatitis B related HCC. So in comparing both SHARP and Asia Pacific studies, sorafenib had a median OS of 10.7 months versus 7.9 months of median OS of placebo. And in Asia Pacific study, median OS was 6.5 months versus 4.2 months of placebo. Median time to progression in SHARP trial was 5.5 months versus 2.8 months in the Asia Pacific trial. The predictors and predictors of sorafenib benefit in HCC was again analyzed by a pooled analysis of phase 2, phase 3 trials, SHARP and the Asia Pacific trial. Extrahepatic spread, chronic HCV infection, and neutrophil lymphocyte ratio. All three are independent variables predicting the beneficial effects or the survival in these patients. Patients with higher extrahepatic spread had lesser overall survival, and patients with chronic hepatitis C related HCC had better median overall survival, and patients with higher neutrophil lymphocyte ratio had worse outcomes with sorafenib. The major adverse effects are diarrhea, hand, foot, and skin reaction, alopecia, and anorexia. Diarrhea and skin foot reaction usually managed initially by reduction of the dose. However, this can be severe enough that that compels a patient to discontinue medications. For over 10 years, there were multiple other tyrosine kinase inhibitors, which was done in multi-center randomized phase 3 clinical trials, which were compared with already established sorafenib. Those were sunitinib, revinib, erlotinib, and linifanib. All these drugs failed to show any efficacy over the already existed sorafenib efficacy. In 2018, the REFLECT phase 3 multi-center trial, that is REFLECT trial, which compared the efficacy of another tyrosine kinase inhibitor, that is lenvatinib, comparing the efficacy with sorafenib, was released. So it was approved as a first-line agent in 2018. This was a non-inferiority trial where patients with no prior systemic therapy for unresectable HCC with more than one measurable target lesion, BCLC-B who are not eligible for TACE, BCLC-C stage patients, child-pug EA category, and ECOG performance status of less than 1 with adequate organ function were included. The exclusion criteria here are more than 50% of liver occupation by the tumor, clear bile duct invasion, or main duct PVT. So this stratification was the stratification done at the regional levels at Asia Pacific and Western, with main vascular invasion if it's yes or no, extrahepatic spread yes or no, ECOG performance status, and body weight less than 60 kg and more than 60 kg. Lenvatinib was used at dose of 8 milligram in patients with body weight of less than 60 kg and 12 milligram in body weight of more than 160 kg per day was used. Sorafenib was given at a dose of 400 milligram twice daily was given. The primary endpoint was overall survival, and the secondary endpoints were progression-free survival, time to progression, objective response rate, health-related quality of life, and safety. Lenvatinib is also a multi-kinase inhibitor, which has, in addition to other VEGF receptor activities, it also shows activity against FGFR1 and FGFR1 to 4. Which is not observed with sorafenib. So the new frontline therapy, apart from the sorafenib, was approved in the year 2018. The median OS with lenvatinib was 13.6 months, whereas sorafenib was 12.9 months. Hazard ratio was not much different, not showing much difference between the two medications. However, the progression-free survival and overall response rate was much more in lenvatinib arm compared to sorafenib arm. That's why it was considered as a non-inferiority trial. So when it comes to how to choose between sorafenib and lenvatinib, I think nowadays sorafenib is almost obsolete from the clinical practice, and for all practical purposes, lenvatinib has been chosen as a first-line therapy. It is still a better option if performance status is better, that is ECOG 0 or 1. If less than 50% of liver is occupied with the tumor, where there is no bile duct or bile duct invasion or main portal vein invasion, AFP, higher AFP levels, that is more than 200, chronic hepatitis B infection-related HCC, child per gay, and younger age groups. Whereas sorafenib is a better option for ECOG performance status up to 2, more than 50% of liver occupation, chronic HCV-related HCC, AFP less than 200, bile duct or main portal vein invasion, child per B status up to 7, and elderly patients more than 75-year-old, organ transplant recipients, HIV infection or CKD. Most common adverse effects are hypertension, decreased appetite, decreased weight, hypothyroidism, diarrhea, and palmoplantar erythrodysplasia. This PPE accounts to 10 to 15% of patients discontinuing sorafenib. Uncontrolled hypertension, catastrophic bleedings, although rare, and endocrine issues like hypothyroidism are the concerns with lenvatinib. Coming to second-line therapy in HCC, the first drug that we will be discussing is regorafenib. This is approved in the year 2017 based on resource trial. Resource trial was done among previously treated child per gay HCC. Prior toleration for sorafenib is required, and patients who progressed on sorafenib therapy are included in this. Regorafenib versus placebo was compared against placebo here, and the median overall survival was 10.6 months compared to 7.8 months, and PFS was 3.4 months versus 1.5 months among the in the placebo arm, which was significantly higher. This also is a multi-kinase inhibitor, which acts on the target receptors of RET, VEGFR 1, 2, and 3, KIT, PDGFR beta, FGFR 1 and 2, RAF1, RAF, etc. It's used at a dose of 160 milligram every day for 3 weeks in a 4-week cycle. 1 week is a drug-free interval. It is available as 40 milligram tablets, and 4 tablets are given in a single day. The adverse events were reported in almost all the regorafenib recipients in the resource trial. That is 374 patients, 100% of these patients, versus 179 patients in the placebo arm. The most common clinically relevant grade 3-4 treatment emergent adverse effects were hypertension, which was seen in 57 patients, that is 15% of the treatment group, hand-foot skin reaction, fatigue, and diarrhea. Coming to the next second-line therapy, it is cabozantinib, which was approved in the year 2019 based on Celestial study. This was the Celestial study studied the effectiveness of cabozantinib in previously treated child per A HCC who showed disease progression on 1 or 2 prior therapies. So this can be used as a third-line option too. And in this study, cabozantinib was studied against a placebo, where median OS was 10.2 months compared to 8 months in the placebo arm, and median PFS was 5.2 versus 1.9 in the placebo arm, which was clinically significant, showing the effectiveness of cabozantinib among these population. This also is a multi-kinase inhibitor, targets RET, MET, and VEGFR 1, 2, 3, and KIT receptors. It is available in 3 strengths, 20 milligram, 40 milligram, and 60 milligram tablets. In HCC, we start with 60 milligram per day. The adverse effects are GI hemorrhage, perforations, any elevation of liver enzymes more than 10 times the upper limit of normal should be considered as a serious adverse reaction and warrants a drug discontinuation. And bilirubin elevation more than 2 times the upper limit of normal. Any occurrence of myocardial infarction or cerebral infarction or major thromboembolic events, nephrotic syndrome, or uncontrolled hypertension should warrant a drug discontinuation. Although not a tyrosine kinase inhibitor, just for the sake of completion, I'll be touching a little bit about ramucirumab, which is a monoclonal antibody against VEGF receptor 2. This was studied in REACH and REACH-2 trials. In REACH trial, this was a negative RCT where ramucirumab versus placebo was tried in previously treated in patients who were previously treated with sorafenib. However, a subgroup analysis in these patients with AFP more than 400 showed survival differences, which led to designing REACH-2 trial, where the inclusion criteria included patients who had AFP of more than 400 nanogram per ml in a previously treated in patients who were previously treated with sorafenib. This again compared the effect of ramucirumab with versus placebo. This was a positive RCT. This was approved in the year 2019 based on the REACH-2 study. This is given at a dose of 8 milligram per kg body weight IV once in 2 weeks. And discontinuation is drug discontinuation is warranted in case of PRES because of uncontrolled hypertension, arterial thromboembolism, GI perforations, and hemorrhagic complications. This is a graphical representation of Kaplan-Meier analysis showing higher median OS of ramucirumab arm compared to placebo. So this is the analysis of REACH-2, which was done in patients who had AFP of more than 400 nanogram per ml, where median death the conclusions on the ramucirumab. It's a first positive study in a biomarker-defined patient subpopulation. The validated angiogenesis as a therapeutic target in advanced HCC. Because the mechanism of action of is specifically inhibition of VEGFR2, the safety profile is distinct from other tyrosine kinase inhibitors. It's a monoclonal antibody with side effects like hypertension and hyponatremia. It does not exhibit other TKI-related side effects, which may provide a clinical advantage for patients like diarrhea or skin reactions. So what are the factors influencing the treatment decision in frontline? When we are choosing between sorafenib and lenvatinib, we have to compare what is the EHS or HCV etiology or AFP level. In comparison of adverse effects like palmoplantar erythrodysplasia, hypertension, or catastrophic bleeding should be considered. In second line, patients who failed either sorafenib or lenvatinib can be switched over to cabozantinib. However, patient with more than 400 AFP, ramucirumab can be chosen, and regorafenib in patients who have previously tolerated sorafenib. And the second line immune checkpoint inhibitors are also reasonable option in the second line treatment of HCC. The pros and cons based on safety profile for ramucirumab versus regorafenib and cabozantinib is here. The ramucirumab is very well tolerated and efficacious, and adverse effects are lesser compared to TKIs. This may include bleeding, hypertension, and proteinuria. Regorafenib and cabozantinib may be higher in efficacy than the ramucirumab. However, adverse effect profile may be much more higher. So coming to the other ongoing phase 3 trials, the COSMIC trial, which is studying about the efficacy of atezolizumab with cabozantinib combination versus sorafenib, and Himalaya 3 trial, which has already been explained in detail by Dr. Anand Kulkarni, which is in line for frontline therapy. Shall not be explaining in detail. The COSMIC 312 trial has shown better median progression-free survival with cabozantinib with and atezolizumab combination compared to sorafenib. And next, coming to launch trial, where a TKI is compared with a transarterial chemoembolization, which also has been discussed this meeting earlier. This concluded that the lenvatinib plus TACE was much safer and effective for patients with advanced HCC, demonstrating remarkable improvements in overall survival, progression-free survival, and ORR, as well as acceptable toxicity. lenvatinib plus TACE may represent a potential new frontline treatment option for patients with advanced HCC. This is another ongoing trial where LEAP 002, LEAP 002 study, which studied the effectiveness of lenvatinib with pembrolizumab versus lenvatinib alone as a first-line therapy for advanced HCC. And this study concluded that the combination of lenvatinib plus pembrolizumab is no superior than lenvatinib alone as a first-line therapy. So the concluding remarks is the choice of first-line drug in patients has to be made considering a lot of clinical details. Affordable patients who are safer to receive immunotherapy should be considered for Atibev combination. If not, tyrosine kinase inhibitor, sorafenib or lenvatinib, of which lenvatinib is used most frequently due to its safer adverse effect profile compared to sorafenib. And median OS in the first line treatment is approximately 14 months and beyond with the current available therapies. And the second line median OS is nearly 8 to 11 months. Making a treatment decision at second line also has to be made considering various factors like response or tolerance to sorafenib and patient safety profile or adverse effect profile. And there are unmet needs. There are more third line therapies that are needed in the management of HCCs in patients who cannot tolerate cabozantinib or following the immune checkpoint inhibitors, changing it to third line therapies. These are the unmet needs and probably open for future research. By this, I would like to conclude my talk. I would like to thank Roche and Isai and Dr. Mithun Sharma for giving me this opportunity. Thank you.
Yeah, thank you, Soumya. So last but not the least, as they say, the king comes in the end. So the only person in this entire group today who can give possibly a curative treatment is the intervention radiologist. So I welcome Dr. Vivek to talk on local regional therapies in HCC.
Okay, thank you, sir. I'll just do the 1 sec. Is my screen visible, sir?
No, sir.
No?
No.
1 second. One second, sir. I'm just sharing the screen. Sorry for that. Actually, I'm Is it visible, sir, now? Is my screen visible now?
Yes, it's visible.
Yeah, okay, sir. Thank you. Thanks for Dr. Mithun Sharma, sir, for giving this opportunity and also for the sponsors for this talk. So I'll be talking about the loco-regional therapies in HCC. Okay, so now everyone has talked this slide. I think already everyone has touched about this advanced and the unresectable HCC. So I will be talking about what are the new changes which have come in the early stage and the intermediate stage HCC, and also in the very early stage HCC with regards to the loco-regional therapy, and also in the advanced stage HCC. So coming to the very early stage HCC, what the latest guidelines is saying is if the patient is a potential candidate for LT, so then we can go ahead and do the resection. And if the patient is not a candidate for LT, then we can do an ablation and give a curative intent with an increased overall survival of more than 5 years. And if the patient is again having a less than only single lesion or less than three nodules with less than 3 centimeters, again we have to evaluate whether the patient is a candidate for resection or an LT. And if the patient is not a candidate for resection or an LT, again he will go for ablation. And one new thing which has come here is a early stage HCC, a single lesion which is less than 8 centimeters. And in this new update, the radioembolization has been included. This is based on the legacy trial where they included 162 patients and they increased that the overall survival was increased up to 3 years in 82% of the patients, either by including a radioembolization. That's why this one thing has been included in this new BCLC update. So either you give a curative intent or you do a downstaging so that the patient will either undergo resection or the transplant. So this has been the whole hallmark of the loco-regional therapies. So coming to each thing I'll discuss. So coming to the loco-regional therapy, so these are the minimally invasive therapies which are directed towards the liver tumors. So liver tumor directed procedures. So the majority the 4 things which are there are ablation, chemoembolization, that is called as transcatheter arterial chemoembolization TACE, combination therapy, and the radioembolization, that is the transcatheter arterial radioembolization or CERT, which is called as. So I'll come to the ablation therapies first. So in the predominant ablation therapies, the most common ones are the radiofrequency ablation and the microwave ablation. And both the ablation therapies, we are looking at the curative intent in order to cure this HCC. So the best, the selection criteria, depending on the size of the HCC, is the size which is less than 3 centimeters for both the ablation. And for the microwave ablation, we can use a slightly larger lesion. Again, these are not exactly the cutoff. What we say is if it is 3 centimeters, what if the patient comes with a 3.2 centimeter HCC? If the patient comes like that, what the data is showing is microwave ablation can be used for slightly larger lesions up to 4 centimeters. But in all practical experiences, we are not using microwave for more than 3.5 centimeter lesions in order to give a curative intent. So in this study, when they have done a long-term effectiveness of the resection and radiofrequency ablation for HCCs which are less than 3 centimeters, the overall survival at 1 and 3 years is similar between the surgical resection as well as in the ablation group. In this study, they have taken the 544 child A patients, where 246 went into the resection group and 298 in the radiofrequency group. And the 4-year overall survival was similar, that is 74% in the resection group and 66% in the radiofrequency group. And the recurrence rate were also similar, that is 56% in the resection group and 57% in the radiofrequency group. So coming to this, in a single HCC, which is less than 3 centimeters, the ablation is almost equivalent to the resection group according to this last study. And this is what we are also following. If the patient comes with a lot of other issues with an elderly patient, if it is not a candidate for surgical resection with the high HVPG of more than 10, then ablation is the first go option. And after the curative intent, we can keep the patient on follow-up, or we can use as a bridge for the transplant also in the later stages. So coming to the radiofrequency ablation, in the radiofrequency ablation, what we use is an alternating electric current is used, and the RF electrode is kept within the target lesion, and grounding pads are kept on the skin. That is, this is kept in order to complete the circuit. And once this is done, oscillation, what happens is once we start the ablation, it causes the oscillation of the tissue ions, and it causes the frictional heating, which causes the coagulative necrosis and the cell death. But one downfall of this frictional heating and the oscillation of the tissue ions and the coagulative necrosis is it causes charring within the tumor. So once it causes the local tissue charring, the heat is not dissipated across the tumor, which increases the resistance for it and also increases the impedance. And the another downfall of the radiofrequency ablation is the heat sink effect, what we have always talked about. The heat sink effect is when the lesion is very close to a larger vessel or any of a portal vein or a bile duct. What happens is the effective ablation doesn't happen because the sufficient heat is not produced because of the way it does. So this is what is one of the downfalls of the radiofrequency ablation. That's why we have to carefully choose which ablation we have to do depending upon where the tumor is located. So another one is some of the challenges which we face in the ablation is the difficult window. Many times in an MRI, the lesion is picked up, but we are not able to see the lesion on ultrasound. And this is what happens in usually majority of the some cases where we usually, even if it is less than 2-3 centimeter, we usually do TACE for such lesions. This is the difficult window lesions where they are subdiaphragmatic lesions. And also we are more careful in order to not cause a diaphragmatic injury and cause a diaphragmatic injury or some amount of pleural effusion or a bile leak into the pleural cavity. And another one is the subcapsular lesion. So what happens in the subcapsular lesions is, if we try to do a radiofrequency ablation for it, the adjacent structures like either a colon or a kidney can get ablated. So these are some of the challenges which come in the radiofrequency ablation. So coming to in order to overcome this, nowadays, predominant majority of the cases, we have moved on to the microwave ablation. Slightly the cost is more, but there are some significantly good advantages as compared to the radiofrequency ablation when compared to the microwave ablation. In this, there is an oscillating microwave field which causes the continuous realignment of the water molecules, and the microwave electrode is kept within the tumor. So this overcomes the heat sink effect because the mechanism is different of producing the heat, and it overcomes the heat sink effect and also the tissue impedance. Because the charring is less, the tissue impedance is also less in the microwave ablation. And the lesions closer to the vessels can be taken care in the microwave ablation as well. But in a study which was shown as the microwave, they have compared the efficacy of the microwave ablation versus radiofrequency ablation. A systematic review and the meta-analysis was done. In this, there is no difference in the local recurrence or progression between the RF and the microwave ablation in this study, where 450 patients were evaluated. But in our practical experience, we use the microwave ablation whenever there is a subcapsular lesion or the lesion is closer to a vessel. We usually go for a microwave ablation. And one thing in coming to another one thing is in the BCLC update, again, we can slightly do beyond the Milan criteria. They have tried in these 450 patients whether if a tumor is more than 5 centimeter or if there are more than 3 nodules. That at least in the practical experience, we have never done only the microwave ablation for these lesions. In this study, what it is being told is the local tumor progression is less in microwave ablation when compared to the RF ablation. And microwave ablation is again prevents the progression, local tumor progression, and also the recurrence in the larger tumors. That is more than 3 centimeter is what it's been told in this study. That is what they have studied about the microwave ablation. So coming to this ablation therapies, so these are the predominantly used ablation therapies, at least in our day-to-day practice. And in the same study around the complications which we can encounter, and again, we have to keep in mind before doing the ablation therapies, the complications are reduced. The major complication is around 2 to 5%, and the mortality is less than 1% in the ablation therapies. So predominant vascular complications are the bleeding, portal vein thrombosis, and the hepatic infarction. These two are quite rare. Bleeding is more commonly encountered either by the capsule or from an artery, which is which is usually intervened during the ablation therapy. And coming to the biliary complications, can be biloma or a bile leak, or we can expect a biliary stricture when the lesion is very close to the bile duct. These complications are more common in case of microwave ablation because microwave is a more aggressive ablation. So we can expect more of biloma stricture in microwave ablations. So we have to be slightly aggressive when we are doing the ablation. And hepatic abscess, this is a very rare complication. And some of the extrahepatic complications are quite common. Pneumothorax, this can happen whenever the lesion is slightly near the diaphragm, or whether there is a path of the pleura between the skin and the lesion. Sometimes inadvertently the pleural puncture can happen when we can see a pneumothorax or a hemothorax we can see. And bowel injuries are usually common in case of an subcapsular lesions, where the colon is very close to the tumor and even the colon can get ablated. So these are some of the things which we should keep in mind in the ablation therapies. And coming to the point, ablation therapies mainly to do a curative intent and also to do a bridge for a transplant or a resection. And coming to this is one of the case which I want to show. This was a 51-year-old female which was a HCV positive and decompensated CLD. She also had mild ascites and she presented with the AFP. But at presentation, her AFP was 15 nanograms per ml. And triphasic MRI of the liver was done. We showed a HCC in the segment 8 of the liver. And also a thrombus was shown in the MRI. That's a bland thrombus in the main portal vein, right portal vein, and the left portal vein. And this was actually a little bit of a suspicion whether this was a tumor thrombus or a bland thrombus, because again, the whole the treatment therapy will change in case of this. But the MRI showed it's only a bland thrombus. There was no enhancement. There was only a bland thrombus in the arterial phase. We can see this is the late arterial portal phase where there is only a bland thrombus within it. And we can also see the ascites which is there. And these sort of lesions become a little challenging for us whenever there is an ascites, because we expect more bleeding to happen in such cases. So this was a HCC, the same case where there was a HCC in the segment 8, which showed 2 into 1.7 centimeter. So according to our guidelines, it comes within the ablation criteria, less than 3 centimeter solitary lesion. The only challenge was the ascites, which had to be taken care of. And this ascites was taken care. We put a needle, we put a cannula, drained the ascites before going ahead with the ablation. And then the ablation was done. And as a protocol, all the patients were monitored for the first 4 hours and then discharged the next day. And the patients were called back after 1 month. So this patient came back after 1 month. And now there is no ascites. As we can see here, this ascites in the T2 weighted image, what we are seeing here is disappeared here. Probably the curative intent for which it was seen. And also there was no enhancement in the arterial phase, which was seen here. This is the post-ablation case. So this patient actually came up after 1 month, and now the presenting AFP is 8, and now there is a complete response on MRI. So our protocol is after the ablation, we call the patient for 1 month, and if we see a complete response and no new lesions, we call the patient after 3 to 6 months with only the AFP and an LFT. And if there is any suspicious, then we go ahead and do a triphasic MRI within those things, and then do a 3, 6, 9, and 12-month follow. And if there is no lesions, and then yearly follow for these lesions. I think this is how the hepatology and the interventional radiology is how we decide as a multidisciplinary team. And this is coming to the ablation. And some of the newer technologies have come in the ablation. And these are the cryoablation, laser ablation, and the irreversible electroporation. Cryo and laser are still not widely accepted, but the irreversible electroporation has come in, where it's a non-thermal ablation which causes creates a pore in the cell membrane and causes the cell death. And this is again indicated in those lesions which are closer to the large bile ducts and less than 3 centimeters. Again, we are not using it in the routine day practice. We are predominantly using the RFA and microwave, and the results have been more than satisfactory in less than 3 centimeter lesions. So coming to the next amount of local regional therapy. 1 second. Yeah. So combination therapy. So coming to the next lesions, that is in between 3 to 5 centimeter HCCs. So what can we do for 3 to 5 centimeter HCCs? Again, the data suggests that we can combine a TACE with the microwave ablation or an RF ablation in order to give a curative intent, because the curative intent is only was described for those lesions which were less than 3 centimeter. So in nowadays, we can actually try to do a curative intent for those lesions which are between 3 to 5 centimeter as well. So what happens in this combination therapy is it is again superior to TACE alone, because the chemoembolization, we are looking at a palliative intent with a recurrence rate and a follow-up we have to keep the patient. So this combination therapy is superior to TACE alone in the treatment response and the overall survival. And what we do in the routine practice is microwave. First we do TACE, and then we do within 48 hours, we do the microwave ablation. And why we do this is after doing the TACE, if we do the microwave ablation, it enhances the efficacy of the microwave ablation as well. And the mechanism is, once we do the chemoembolization, the lipidol goes into the tumor, so the tumor is better visualized even on ultrasound. Sometimes the difficult location tumors, like those tumors which are there at the subcapsular or in the subdiaphragmatic location, can be better seen post TACE, and even we can target those lesions on fluoroscopy also. And after the TACE, what we do is, once we stop the perfusion for the tumor perfusion related cooling is also reduced. So that enhances the efficacy of the ablation as well, because in the TACE, we knock off the artery by giving a gel form at the end. So which I'll come to, which we'll discuss in the next few slides, the mechanism of the TACE and the action of the TACE. So the perfusion related cooling is also reduced. So the ablation becomes more efficacious because there is no vascularity or no vasculature perfusion within the tumor. And the lipidol which is deposited within the tumor is also causes a stronger heat conduction, and it also increases the edema, which again increases the heat conduction and causes an efficacious ablation. So this is how the combination therapy helps. And this is our new protocol in our day-to-day practice for the 3 to 5 centimeter lesions. And coming to one example of the case, 67-year-old male, which is a HCV positive, child A, and he presented with an AFP of 1654 and HCC, which is in the triphasic MRI, there was a HCC in the segment 7, which measured 3.8 into 3.4 centimeters. So again, it comes under the criteria for the combination therapy. So this was the MRI, so which I can, this is the diffusion weighted imaging. Again, an excellent sequence in order to detect the HCCs, where the tumor just lights up, which is a hyperintense on diffusion weighted imaging. And in this lesion was not particularly arterially enhancing. It is mildly arterially enhancing, but a washout is seen in the venous phase. So this is a clear-cut HCC in the segment 7, which is about 3.8 centimeter. And for this, again, the TACE was done first. So this was the TACE where the microcatheter is placed in the tumor feeding artery, and then the lipidol was injected. And this is the uptake of the tumor, or this is the lipidol uptake within the tumor. And this was slightly challenging case. That's why a little bit of we can see a little bit of lipidol, which is there in the regular parenchyma also. What happens is, if the bilirubin is good, we can actually try to take this sort of risk, because if the bilirubin is 1 or less than 2, we can still do these sort of cases, or else we have to be very selective and very careful in doing the TACE, and we have to avoid the lipidol going into the regular parenchyma. But in this case, this was okay. And then after that, we did a microwave ablation after 48 hours and then called the patient back after 1 month. And this is the present MRI after 1 month MRI. So we can see there is a complete response which is seen. So there is no diffusion restriction and there is no arterial enhancement. And in the venous phase also, we can see the complete necrosis of the tumor. And then the AFP has reduced from 1,600 to 5.5. So this is at 1 month. And again, this patient also we are keeping on follow-up because he's an HCV positive. We have to keep the patient on follow-up for the next 3 months. We have to call back the patient again after 6 months and 1 year. So this is about the combination therapy. So coming to these two, the ablation and the combination therapy has been done with a curative intent, where we can do a curative intent for the HCC. And now coming to the intermediate stage HCCs, where we do something called as where we do a procedure that is a transcatheter arterial chemoembolization, that is TACE. So how the TACE has been, what are the standards of TACE and what is our practical experience with the TACE is what I'm going to talk about. And in the patient selection criteria is the BCLC, TACE is indicated in the BCLC-B intermediate stage, and those candidates for non-surgical candidates and not amenable for the percutaneous ablation. And again, in the multinodular HCC who have a preserved liver function, there is no vascular invasion, that is no portal vein invasion. Again, this is not an absolute contraindication. Nowadays, even with the branched portal vein thrombosis also, we can do chemoembolization and no extrahepatic spread, because again, it won't increase the overall survival. Even with these sort of cases, the TACE has not shown to increase the overall survival if there is already an extrahepatic spread. And TACE is also used as a bridge for the liver transplant. And these are the ideal candidates. When we choose the candidates, the child-Pugh score is less than 8. Less than B8 is the ideal candidates for TACE, and the size has to be less than 7 centimeter. If a single lesion is there less than 7 centimeter, we can take for TACE. And nowadays, according to the legacy trial, we can even take a solitary lesion of less than 7 centimeter or less than 8 centimeter can be taken up by the radioembolization also. But in Indian scenario, the radioembolization, again, the cost factor comes in. So we cannot use the Western standards for the Indian standards when we are giving the standard of care. And the total number of lesions are less than 4 to 5 lesions are the ideal candidates. So even if there are more than these lesions, then we have to do something called as a stage TACE. Or even in these cases, if we reach the lipidol limit, we do call the patient for a second stage TACE after 2 weeks. So these are the ideal candidates. And another objective criteria, what we are taking is the ALB grading, where only albumin and bilirubin is taken. In our day-to-day practice, the bilirubin cutoff is 2 to 2.5. More than 2.5, we have to prognosticate, and we have to be very careful if we are taking up for TACE. And albumin of more than 3.5, if it is there, then it's a good indicator. This is a negative grading, actually the ALB grading. So the grade 1 are the ideal best candidates. If the score comes to less than 2.6, then these are the best candidates for TACE, who show a good response and also the good overall survival according to the data. And the grade 2 and grade 3, again, these are beyond the guidelines, because there is stretching the guidelines. We can take the grade 2 patients, but again, the local recurrence and the overall survival is poorer when compared to the grade 1 patients. So what happens in the child B and C beyond the guidelines? So in this study, what they have done is the outcomes they have studied in the HCC in cirrhotic patients with a compromised liver functions. That is, they have taken 100 patients of child A and 90 patients who belong to child B and child C. So according to this study, which was published, so regardless of the child's classification, the necrosis is similar in case of TACE. That shows that basically in TACE, when we do the chemoembolization and we do knock off the tumor feeding artery, it achieves the similar tumor necrosis, but we have to be more careful in the child B and child C. So we have to do a super selective and an ultra selective TACE, that is, avoid the non-target non-tumor feeders and selectively cannulate all the tumor feeders and give the chemotherapeutic drug and knock off those arteries. This is what is the super selective and ultra selective TACE is. But however, in the post-TACE survival is inferior compared to child A. That is anyway expected because of the compromised liver function in the child B and child C. The post-TACE survival is not as great as in cases of the child A, is what it shows. But however, the MRI tumor necrosis is similar in both child A and as well as in the child B and child C. So some of the contraindications for TACE would be the advanced cirrhosis, that is a child C, and performance status more than 2, and if there is a significant extrahepatic tumor burden, or if there is a medically refractory hepatic encephalopathy. These are some of the contraindications for TACE. So coming to the TACE, which I will go into some detail between the conventional TACE and the depth TACE. So in the conventional TACE, what we do is a chemotherapeutic drug is there, which is mixed with the lipidol. And then after injecting this into the tumor, we are following it by an embolic agent into the tumor feeding artery. So which are the chemotherapeutic drug which we are using? In our predominant day-to-day practice, we are using doxorubicin, even cisplatin can be used. And in the Indian patients, the limit in the conventional TACE is around 50 milligrams of doxorubicin. which we can use in per session so that it is well tolerated. The only contraindication is the cardiomyopathy. So that's where if the patient is a cardiomyopathy, we have to be careful in doing the conventional test. And the lipidol is used, and the lipidol, what the advantages the lipidol does is it carries the drug. It's a tumor seeking agent because it selectively goes towards the tumor because of the tumor pump, which selectively takes the lipidol into the tumor cells and not in the regular hepatocytes. And it's also an embolizing agent. So this is how the lipidol and the doxorubicin is mixed and injected into the tumor feeding artery. After up to the stasis, we inject this and then we follow it by the gel foam. The gel foam is the one which causes the embolization of the tumor feeding artery, so which causes an effective necrosis and also the tumor death. Coming to the depth test, so another thing is there where we use a drug-eluting bead test. So in this drug-eluting beads, either the DC beads or the HEPA spheres are used. The DC beads are the PVA microspheres which are loaded with the doxorubicin. So what is the advantage when compared to the conventional test? In the DC beads, what we use is in the conventional test, as I told, the limit is around 50 milligrams because when we give the drug, this doxorubicin in the conventional test can go into the systemic circulation, and that's why the patient can poorly tolerate it. Whereas in the depth test, 75 milligram to 150 milligram of doxorubicin can be used, and these beads selectively go into the tumor and into the tumor bed, and these are smaller particles. They stay there and they cause the effective diffusion of the doxorubicin only to the tumor and the tumor bed, and the reduced systemic toxicity is seen. And this is why these depth tests, when we are deciding on the technicalities, whenever the patient comes with a poor hepatic reserve or a child B8 and above, we can think of using depth test if you want to do. And also in the larger tumors where we cannot use more than 50, if we have to use more than 50 milligram of doxorubicin, or if we have to use more lipidol where we cannot use because of the size, then we can think of depth test. So these are some of the advantages of depth test over the conventional test. So as I told, in the child B8 and above, we can use the depth test, and also in the larger tumors we can think of doing depth test. And also another one important thing is, I will show some of the images where patients where the MRI is contraindicated because either due to some of the implants or some of the cardiac pacemakers, or where the patient is claustrophobic, where the patient doesn't want to get the MRI done post therapy, then we can think of depth test, because if we give lipidol, then on CT we really can't evaluate the treatment response that effectively. In that way, if we use the depth test, even we can do the post therapy follow-up can be done with the CT also. And if we are using multiple sessions, for example, if the tumor is, if there are more than if there are 4 to 5 lesions where we have to do multiple sessions, or if the size is more than 8 centimeters, we have to use multiple sessions, then the study indicates that depth test shows a far greater efficacy when compared to the conventional test. So again, coming to the post-test complications, it's fairly well tolerated, and the major complication is less than 1% in a large study where they included around 566 patients. So some of the expected complications are the post-embolization syndrome, where this is a transient, where there is a transient elevation of the enzymes, fever, vomiting, and nausea is there, which can be treated with the symptomatic treatment. Whereas more challenging complications are the decompensation or the ascites. And this is again seen in cases of the child B8 and above. It's more common. That's why we have to prognosticate, or we have to use a tougher selection criteria while choosing the patients. Liver abscess, again, liver abscess cholecystitis is very rare, and tumor rupture is also quite rare. But these, even we have seen one case of tumor rupture, and these are encountered in the subcapsular lesions, which have a predominant exophytic component. So coming to one of the examples of the case, so 54-year-old female, which presented with she was a HCV positive, again child A, and an AFP of 160 nanograms per ml. So this patient had 2 lesions. One is a 3.8 centimeter, which is subcapsular in location, and another lesion was 2 centimeter. So because it was subcapsular in location and it was abutting the stomach, the decision was taken not to do the ablation because it was in a challenging location in the segment 2. And we could have done an ablation for this lesion, but again, the thing was taken to do a TACE for these 2 lesions, followed by an ablation for only one of the lesions, because segment 2 anyway we couldn't ablate. So this is the angiography which shows a good tumor blush, and here we have done a conventional TACE with the lipidol for the segment 2 lesion. As we can see, it is in the edge of the liver, which is close to the stomach and also to the diaphragm. And this is the another segment 8 lesion. As we can see, it was a very tough and tortuous hepatic tumor feeding artery. And as we can see here, the uptake of the lipidol is not as great as in this lesion. That's why, because of the very small artery was there where we couldn't give that much of lipidol. And hence the decision was taken to do a microwave ablation of this lesion as well. And we did a microwave ablation for the segment 8 lesion. And the patient was called back after 1 month as the protocol. And this is the follow-up MRI after 3 months, and which shows a complete response of both the lesions. Though this is the segment 2 lesion, as we can see, it is very close to the stomach here and exophytic component. And this is the segment 7/8 lesion, where the TACE and an ablation was done. And both the lesions show a complete response on the MRI. And AFP was reduced from 116 to 8 in this particular lesion. So I'll just go through this thing. One of the another newer armamentarium which has helped us in treating the TACE is the C-arm CT or a cone beam CT or a Dyna CT, where in the cath lab table we can produce a CT image after cannulating the celiac or a hepatic artery and giving contrast from there. So precisely identify the feeding arteries during the TACE. And what happens is we can see the difficult and the smaller vessels can be seen much better in the Dyna CT, and we can cannulate them much easier, so that we can do a super selective and an ultra selective TACE. And also the identification of the smaller HCCs also are done, because those smaller HCCs which are not seen on the MRI or a DSA or an MDCT are seen better on the Dyna CT on table. So again, we can we can change the protocol, or we can do a TACE for the smaller lesions as well. So this is one thing which has changed our treatment protocol. And coming to the last loco-regional therapy, the TARE. Earlier, TARE was only used for the advanced stage HCCs, but nowadays, the 40% of the patients who are diagnosed to have intermediate stage HCC, intermediate or an advanced stage HCC at the time of diagnosis. So these sort of these patients can be taken care by the radioembolization, that is the liver confined HCC, who are unresectable either due to the poor hepatic reserve, or they have a poor performance status, or due to the comorbidities. So what happens in the TARE is the larger tumors can be taken care of. Even a solitary lesion of a child day of less than 8 centimeters can be taken care by TARE, where the survival is around 80%. The only drawback of the TARE is the cost when compared to the Indian scenario. And also the portal vein thrombosis, the segmental or a lobar branches up to VP3 portal vein tumor, that is up to the right or a left portal vein thrombosis, we can do TARE. When it's a main portal vein thrombosis, either we have to combine the TARE with SBRT or combine the TARE with immunotherapy, and we can do the TARE for bridge for resection or the liver transplant. So when we do a bridge for resection, it's an hypertrophy of the treated lobe. When the treated lobe undergoes atrophy, and the contralateral lobe undergoes hypertrophy, so the FLR increases, so the resection can be done. So these are some of the advantages of the radioembolization. So as in the radioembolization, again, the intraarterial injection of the radioactive compound is done. These three are the radioactive compounds which are used in TARE, which are described, that is the yttrium-90, lipidol labeled iodine-131 or a rhenium-18. But the predominant we use is the yttrium-90. And the microspheres which are coupled with these radioactive compounds are the theraspheres or the SIR-spheres. We have used both with excellent results in both theraspheres as well as in the SIR-spheres. So coming to just the technicalities of the TARE, where we do it in the 2 stages, that is in the MA planning angiography in stage 1 and Y90 actual radioactive administration in the stage 2. So what happens in the MA angiography is we go into the tumor feeder and inject the macroaggregates of the albumin. So these compound, they behave similarly to that of the Y90 microspheres. The MA behaves similarly to Y90 microspheres. So the lung shunt fraction can be calculated. So once the LSF is calculated and it comes to less than 20%, we can go ahead and do the Y90, or it causes a radiation-induced lung damage. And even the tumor to normal liver uptake can be seen. So if the MA goes selectively into the tumor and nicely into the tumor, then even the Y90 goes, and that's what shows a better response. So this is how we can do a patient selection also, because many times after MA angiography, we can take a call on whether to really go ahead and do Y90 or not, because the Y90 itself is a slightly costly drug. So this is how we are doing in the 2 stages, and after the stage 2 can be done within 4 weeks after doing the MA planning angiography. So from this thing, what nowadays, even we can include the early and the intermediate stage HCCs as well, with an ablative intent of less than 8 centimeter, as I discussed before in the legacy trial, which was shown that less than 8 centimeter HCCs can be included. And even a radiation segmentectomy and radiation lobectomy can be planned. That is, the entire radiation can be given to the one segment where the tumor is there, so that the tumor as well as the satellite nodules and the microvascular invasion can be taken care of. And if a multifocal HCC is confined to a single lobe where we cannot do a resection, then we can do a radiation lobectomy followed by a resection or a transplant. So these are some of the advantages of the radioembolization. And nowadays we are doing in a multifocal HCCs with both lobes are involved. Then the larger tumor can be taken care by the tear combined with the newer immunotherapy drugs. And in some of our recent experiences, it is even the data is limited, but we are seeing an excellent response with the tear with immunotherapy as well. So coming to one of the practical, one of our cases, which shows a infiltrative HCC is seen in a diffusion weighted image. And here we can see the this is a 67-year-old male with an infiltrative HCC, and the HCC is entering into the portal vein and up to the right portal vein and the main portal vein. So here we can see the diffusion restriction in the portal vein as well. So, and then the tear was, and the decision was taken to do a radioembolization. So where there is an excellent uptake of the Y90, which is confirmed by the PET scan. And then this is the follow-up after 3 months, which shows a blank thrombus in the portal vein branches, and there is no tumor in the segment 7 and segment 8. So this is the resolution of the tumor thrombus, and this patient underwent transplant and is now disease-free. So this is where the radioembolization comes, where we can do a bridging for either the resection or transplant, or it can be used as a palliative care where we can increase the overall survival. If the response is good, the overall survival is more than 14 to 18 months in case of advanced HCCs as well. So coming to the take-home points of local regional therapy, the tailored approach for each case in consultation with the hepatology department of hepatology and the liver transplant surgeon. And before, a strict selection criteria can be used, but if we are going beyond the guidelines, we have to prognosticate prior to the therapy, and multidisciplinary approach is the way to go for the HCC's treatment, is what I feel. And this is how I would like to end the talk. Thank you.
Thank you, Vivek. That was a very nice presentation. So as we come to the end, our timing was till 9:30. So we will like to end the session today. It was very informative. Would anybody from the sponsor side would like to put in a word? I would thank them for making the arrangement and giving us support for this meeting. Dinesh, anybody from your side would like to give a closing?
Yes, sir.
We can hand over to you.
Thank you, sir. Thank you, everyone, for joining for today's webinar on advances in hepatocellular carcinoma management. I thank everyone for joining, and I would like to thank our academic partners also. Thank you, everyone. Good night, everyone.
Good night.